A little bit of a review on yesterday's training. We had a hospice training yesterday morning and a nursing facility training yesterday afternoon. So what this training does is it pulls all that information together so that both the nursing facilities and the hospice providers have information about each other. It also brings everyone to the table. So we have hospice providers and nursing facility providers on the line. And again, we have our subject matter experts here in the room. But our hope for today is that this will start to open up a conversation between the nursing facilities and the hospice providers so that both parties kind of have an understanding of what's expected of them and what's expected of the other. So hopefully that coordination and communication will start from today. Okay, so I already kind of went over this, and then again, we'll just go around the room real quick. We have pretty much the same parties that we had yesterday, but I'm Jennifer Smith, and I am the OHP trainer. And then we'll go now.
Cindy Susi, Aging and People with Disabilities, Long-Term Care Medicaid Rate.
Jason Singer, APD Field Support Manager.
Calipray, Aging and People with Disabilities Policy. Susan Van Hatten, DMAP Providing Services, liaison. And also with Medicaid DMAP Policy for hospice.
All right, so that's who we have with us today. And we're going to have a review again of the payment process change and billing for hospice clients that are in a nursing facility. We'll talk again about the roles and responsibilities of both providers. And then we'll talk about billing when a nursing facility client receives hospice. And then some discussion points and resources. So again, we're hoping that this is going to open up a discussion between the different provider types. So the payment process change, May 1st, and this is the new process for hospice clients that reside in a nursing facility. The bundled services for nursing facilities will be billed to the hospice that's providing hospice services for that client. And then the hospice providers will bill Medicaid for that bundled payment, including fee-for-service and managed and coordinated care. And then once that payment is received by the hospice, they're going to pay the nursing facility. So again, this is per federal statute. And we must pay at least 95%. Oregon Medicaid has chosen to pay 100% of what the nursing facility would receive. And then again, hospice providers will receive payment and pay the nursing facility. So how do you comply? This again is going to talk about the written contracts that needs to be in place between the hospice provider and the nursing facility. And it should address how the hospice is going to pay the nursing facility and also how the nursing facility would bill the hospice for the services. So that should all be in your contract. And then, of course, both providers will work together to coordinate care for the client and to coordinate proper billing and payment. So the hospice is the overarching manager of care, and they maintain the overall professional management of the medical plan of care. And the nursing facility continues to provide residential and long-term care services. And, of course, coordinate with the hospice while doing so. Okay, so responsibilities of both providers. Let me check our questions real quick. Okay, first question. What supplies are included in the room and board bundled fee? Gloves, wipes, diapers, etc. The supplies in the bundled rate?
Those are some of the. The list is within the rule. I don't have the rule right here in front of me. However, the bundled rate or the room and board bundled rate does include several different items that the nursing facility is required to supply. However, when it comes to hospice, if the supply supplies are related to the terminal illness, then hospice is required to provide those supplies while the client is in the nursing facility.
Okay, and then there's a comment on the sound, so we're doing our best to make sure that that's loud and clear. Hopefully that's a little better. Okay, and I did go back to this slide because Becky was talking about the rule where that information would be, and there is a link to that rule right here on this page. Oh, is that to the hospice rule? Yes. Or 11. Okay, sorry about that. This is to the hospice rule. So also one of the last slides in the slideshow has both the links to the hospice rule and to the nursing facility rule. So you should be able to link to those fairly quickly. Okay, so let's talk about the responsibilities of both providers. What do hospice providers need to do? So hospice providers should initiate or continue hospice services to clients. And again, this should be a seamless process for clients. Clients and their families are kept informed. The hospice should also implement coordination of care and educate the nursing facility staff on the hospice's role as manager of care. Hospice providers will work with nursing facilities to coordinate care. And then hospice will bill Medicaid for both the hospice services and the nursing facility services. And then they'll pay the nursing facility upon receiving payment. And again, hospice responsibilities, nursing facilities, social workers, billing staff, all of those folks should know about process changes. Hospice is confirming Medicaid eligibility with the nursing facility. And in that eligibility, they're looking for Medicaid benefit or qualified Medicare beneficiary. They're obtaining patient liability information from the nursing facility. So the hospice does not have access to the patient liability on the provider web portal. Only the nursing facility does. So that's coordination between the two providers. So they're obtaining that from the facility. And then they're also identifying if a client is enrolled in an OHP plan. Hospice providers also complete and fax the DMAP 525 notification form. So if you're a nursing facility, this was the notification form we talked about yesterday. It didn't actually have the name, DMAP 525, when we talked about it yesterday. And this indicates new hospice service in a nursing facility and any changes in client information. And then hospice also submits the bill to Medicaid and upon payment pays the nursing facility. All right, next we have what nursing facilities need to do. We do have a question coming in. What is patient liability info? So patient liability is an amount that is due to the nursing facility from the patient, and I believe it's based on patient income, whether or not they have that liability. So it's a part of the payment. For example, if the nursing facility would bill Medicaid $2,000, but the patient liability is $500, then upon billing, then Medicaid is only going to pay $1,500 because they're going to expect that that nursing facility has collected $500 from the patient. Now, the way that payment is set up in the system is, regardless of the amount that's billed, it's automatically deducted, that patient liability is. So as a hospice provider, if you were to bill $2,000, our system is going to see that patient liability and automatically deduct it, just as it would if the nursing facility were billing us. Okay, so nursing facilities, oh, that's a good point. So that patient liability is only deducted from the room and board payment, so the bundled services for the nursing facility. It is not deducted from the hospice line item. So that will still pay per Medicaid rules. So nursing facilities, they're going to continue to serve their clients as required by APD rules. Again, it should be a seamless process for clients. Clients and their families are kept informed. Continue to collect patient liability and report that amount or any changes to the hospice. And that should be happening when you bill the hospice anyway. You're going to let them know how much you've already collected. But that also helps them to know how much they should pay as soon as they receive it. It should be written in the remittance advice, so they should be able to see that, but that still needs to be some coordination there between the providers. So nursing facilities need to work with hospice providers to coordinate the medical care and billing. And then nursing facilities will bill hospice for the room and board bundled services. So nursing facility responsibilities. Social workers and billing staff know about process changes. So you'll notice that's pretty similar with one of the hospice responsibilities. That's just that both providers should be sharing with staff, social workers, and the other party any process changes, anything that's going on with the client as well. Nursing facilities will confirm Medicaid eligibility with the hospice provider. So the nursing facility will continue to monitor clients' financial status and liability changes, and notify the caseworker for eligibility changes as needed, and identify if the client is enrolled in OHP plans. Nursing facilities will also work with the hospice to implement and carry out the patient medical plan of care. Again, you're going to continue to collect the patient liability and inform hospice of that amount, and then bill the hospice provider. Okay, do hospices always bill the full amount for room and board? So we did outline in both of the presentations yesterday, and I think I put it in this one too, the procedure or the revenue codes that you would use depending on the level of care for the nursing facility. And yes, you would bill the full amount for room and board. Because what happens with a patient liability is it's set up in our MMIS, Medicaid Management Information System, as a set amount that that client needs to pay for their nursing facility services. So you would bill the full amount, and then our system automatically deducts that from the payment. So yes, always bill the full amount. Okay, so nursing facilities and hospice together are assuring that that current written signed contract is on file between the nursing facility and the hospice. Providers are working together to verify, implement, and carry out the patient's plan of care. They're collaborating to anticipate and confirm Medicaid eligibility and OHP plan enrollment, and then coordinate payment arrangements. And then there's a note at the bottom. The hospice is not responsible for any services included in the all-inclusive room and board rate. Right, and this was information that was included in a quick guide that we had created. I think it was, did we send it out back in November? It's still available online. Okay, very good. So it went out again with the announcement. And this is basically just a breakdown of that same information, a quick guide of what both providers need to do. So if you look at the left, these are items that the hospice will need to do. On the right, this is nursing facility responsibilities. And then down here are items that both providers would do together. Okay, next question. Should there be a contract with hospice for each patient? I would say that there needs, well, not with each patient. It depends on how many hospice providers you're working with. You would need one contract on file for each of the hospice providers that you're working with. And that contract should be consistent across the clients that that hospice is providing services for. All right, and I just wanted to leave that up for a minute so you could take a look at it. And really kind of just a review of everything we've already gone over. So communication and coordination between the two providers. First of all, client eligibility. So the nursing facility is continuing to monitor the client for eligibility for Medicaid. And then the nursing facility still notifies APDs, area agencies on aging, eligibility workers. They prepare for the change in client coverage, and they notify nursing facility and hospice billing staff, social workers, and other staff as that client becomes Medicaid eligible. Both providers verify client Medicaid eligibility upon service initiation, before submitting a claim, and then keep all parties informed again. And again, when you're looking at eligibility, you are looking to see if a client is fee-for-service or if they're enrolled in an OHP plan. And this is just a review of the hospice election. So a physician requests hospice, and then if the nursing facility receives the request, then they would inform the hospice provider. And then, of course, notify the nursing facility and hospice billing staff, social workers, and other staff that would need to know that the client has, or it's been requested that the client would receive hospice. So once the client elects hospice care, then the hospice election form is signed. And that's when you would either initiate or confirm the contract that you have on file, and then implement coordination of care. Okay, so next question coming in. Please clarify where billing is to go for clients in managed or coordinated care. So I believe that we cover that again a little bit later on. But basically, with nursing facility services, you're billing Medicaid directly. Nursing facility is not covered by Medicare or by the plan. So it's carved out of those plans, and you would bill Medicaid directly. So for a hospice provider, if you're providing services to a client within a nursing facility, if a client is enrolled in managed or coordinated care, you're billing Medicaid directly for both the hospice service and the nursing facility service. So hospice providers that are providing hospice to folks outside of nursing facilities, you're still just billing the way that you always have. So those would go to a managed or coordinated care organization. Okay, and this is just more about the reporting. So hospice providers are submitting that DMAP 525. This lets us know that the client has elected hospice, and then we update our system with that information. And if any client changes occur, we need a new DMAP 525 from the hospice provider. The changes might include a discharge from either the hospice or the nursing facility, changes in providers, and date of death. And this is the DMAP 525 form. Okay, so we have another comment coming in. If they have Medicare and Medicaid, hospice bills Medicare for hospice and Medicaid for room and board. That's correct. Because the room and board nursing facility services are not covered by Medicare. So that's the form. We went over that yesterday as well. A question did come up on the fax number and the telephone number, so I just want to point that out at the top. This is where you would be faxing the form to, and then here's the telephone number. I'm going to go back for just a second. Oh, okay. So we also wanted to point out that right here is where you're putting the CCO or MCO name. So that requires client eligibility information there. So I do want to point out that you need to fill that out on the 525 form. Next question. I have a patient here who does not qualify for Medicaid. He is on hospice and has a long-term insurance. Do I bill hospice and expect them to bill the long-term insurance? No. If a client has long-term insurance, then you are sticking with the current process and collecting that from long-term insurance or from the client's family. All right, let's go ahead to financial. Again, both providers are verifying client eligibility. The nursing facility is collecting patient liability, reporting that information to the hospice, and any changes as well. Nursing facility bills hospice. The hospice provider bills appropriately, and then they pay the nursing facility according to their contract. Here are those revenue codes. I mentioned those a little bit earlier. And yes, you would bill at the full amount. Just want to clarify that again. And these are also included in a rate table for hospice providers. And it's on the hospice rules page on DMAP's website. Okay, and then we've already talked about this somewhat, but I have it outlined as well. So client coverage and who you would be billing. So Medicare coverage, again, hospice is covered by Medicare, so you would bill Medicare for those services. Nursing facility services are not covered by Medicare. So if the client is Medicaid eligible, you would just bill Medicaid directly. And then a breakdown of coverage information, and this is where we start to talk about long-term care or long-term insurance, whatever term you prefer. So again, this is just outlining the same thing, that hospice is covered by Medicare, nursing facility is not. Now, a lot of the time, hospice providers, you're billing Medicare, and that claim is crossing over automatically to Medicaid if the client is Medicaid eligible. You can pull up that claim and add the nursing facility services to it and adjust the claim in the provider web portal, and then that'll add that nursing facility payment to it. And then again, long-term care coverage is primary and it's considered payment in full. So if a client does have that coverage, then the nursing facility is still responsible to go ahead and collect that amount. And then the hospice provider would not be billing for that client. And kind of just a longer version of what I just said. Oh, good question. Is the basic rate 658 revenue code the same for all facilities? Yes, that's statewide. And something to keep in mind, I'm sure nursing facility providers are already aware of this, but hospice providers, new rates will be coming into effect on July 1st. So there will be communication about that when it happens. And that's date of service July 1st. Next question, how often do they change? Every July. Every July they could change, every July. Sometimes there's no change, but that's when they're looked at. All right, so billing. And then again, this is all just review. Hospice providers, if your client is not in a nursing facility, then you bill just as you always have. The Medicaid payment could be either directly through Medicaid or through a managed care or coordinated care organization. The only time you're not billing the managed or coordinated care is if the client is in a nursing facility. and then you would bill Medicaid directly for those clients as well. So this slide is primarily for hospice providers. So if your client is in a nursing facility and they have both Medicare and Medicaid, then you bill Medicare for the hospice, and then bill Medicaid for hospice and for nursing facility rates. But that's when you would only bill Medicaid directly and not the plan. All right, and billing details, hospice services, use the usual hospice revenue codes. Reimbursement is per the Medicaid rules. And then for nursing facility services, you're billing using one of the revenue codes as listed on the previous slide, and the usual and customary rate for the dates of service. And that line item, that nursing facility line item, is going to bypass Medicare edits, so you don't need to put a Medicare adjustment reason code. It's just going to bypass it completely, and then we're going to pay that per Medicaid rules. And again, we would deduct any client liability amount from that payment. Next question, on the DMAP 525, why would a hospice include the coordinated or managed care organization name? Since long-term care is not covered by the CCOs till 2014, then why would the CCO be involved?
The CCO is involved because it's important for them to know where their clients are. Currently, we have in the system a method by which the plans electronically get this information, but we've had a delay of that particular piece in the MMIS for this project. So in order for us to know when the form comes in, which CCO or MCO they're with, so that we can manually contact and let the CCO or MCO, this really facilitates that process. And then within a couple of months, hopefully, the electronic piece will be in the system for that notification. Remember, too, that for all the clients that are in a CCO or an MCO, even though this tiny portion of hospice, only hospice when the client is in a nursing facility, is billed directly to Medicaid. If the client has other issues outside of the terminal illness and not related to the nursing facility services, those pieces will still be covered by the MCO or the CCO. An example might be insulin, something not related to the terminal illness and not covered under the room and board bundled rate. So they're still involved with the client.
And just one other clarification on the statement, long-term care is not covered by the CCO until 2014, so not all long-term care is going to be covered by the CCO currently. So long-term care on the aging and people with disability side and developmental disability side is still carved out of the CCO for state statute. So addictions and mental health long-term care is going in. So just a clarification on that point for our providers.
Okay, next question. So just to clarify, the nursing facility needs to bill the hospice with revenue code 658, 191, 192, or 199. Is that correct? Yes, that's correct.
So the hospice would bill with those codes. The nursing facility could coordinate that they're invoicing however they do through the contract. So just, again, making sure that's clear that nursing facilities will not be billing for hospice individuals. Again, the hospice will be billing with those codes. Just want to make sure we make sure that's clear throughout.
All right, let's go ahead and move forward. And all we have left is resources and then some discussion points. So again, as promised, Oregon Administrative Rules, those links are right here. So this one will take you to the nursing facility rules, and this one to hospice. And then, of course, we have the Social Security Act sections. And then billing guidelines and tutorials on our Tools for Providers page. Also, if you need help with anything, we have the DMAP Provider Services Group and DMAP Provider Training that you can contact. And then we had some discussion points that we came up with here, and we would like to go ahead and open up the discussion between nursing facilities and hospice providers. You're still going to be communicating the same way, but if you have some discussion points, go ahead and bring those up. So discussion points that we came up with here, the thorough and frequent communication between hospice providers and nursing facilities, recommended quarterly meetings between the providers and stakeholders to work out issues, hospice outreach to nursing facilities, hospice and nursing facility access to client charts, and Medicaid eligibility anticipation and dual eligible identification. So that's something that nursing facilities are still anticipating Medicaid eligibility. So that's a big piece on coordinating with the hospice. Okay, so we do have a question. Just to be clear, if someone has a CCO, but we need to pay for room and board, we bill the entire claim to Medicaid, not the CCO. So that question is coming from a hospice provider, obviously. And yes, that's correct.
And again, just to clarify on the scope chart, this is only when they're in a nursing facility. So if they're in any other long-term care setting, so assisted living facility, residential care facility, adult foster home, an in-home plan, a specialized living, or any of our other facilities other than nursing facilities, we bill as slideshow previously in their normal format through the MCO, CCO, or DMAP. But this is only for nursing facilities.
Okay, next question. If a hospice is offering to pay the nursing facility more, isn't that illegal, an illegal incentive?
So the state really isn't going to get into some of these legal matters between entities on contracting. We talked a little bit, and you'll see in the rule, we really leave those up for business decisions. So, you know, as business organizations, whatever contracting methodology you use and your own legal counsel or advisement on what is available or legal to you, it's truly a business decision. From the state standard, what we have is that we can state in administrative rule what we will reimburse for a service. So for our services, we've defined that for nurse facility hospice, we will reimburse up to 100% of the daily rate the individual would have received, and we've defined those with the revenue codes, each of the revenue codes covering the different daily rate methodologies that we pay out. So that's what we will reimburse hospice. Then hospice has a contractual relationship with the nursing facility, and that's where, as a state, we allow the business process for those decisions to be made. So while that is a valid question, we put that back for you all in your business decisions to be able to look at all your avenues around what makes sense for you all, and again, hopefully looking at all the legal decisions around those points in the contract.
So I want to make sure that that got to everyone because it looks like I was muted. Sorry about that. So there was a question about long-term care. I don't understand what long-term care coverage is exactly. Can you explain that? So what I explained is that long-term care coverage is kind of like a third-party liability where that client has coverage for long-term care. So a lot of the nursing facilities refer to this as long-term care insurance. So same thing. And basically how that works is that long-term care insurance pays the client or the client's family for those services, and then the nursing facility collects that amount from the client or the client's family. So in those cases, first of all, this is why we need that coordination between the facility and the hospice provider. Because you may have a client that is in a nursing facility receiving hospice care and has long-term care insurance that that nursing facility is collecting. So because it's considered payment in full, then it's still collected by the nursing facility, and the hospice would not be responsible for billing that nursing facility service to Medicaid. Next question. If a patient is in a nursing facility and does not have Medicare, only Medicaid eligible and under a CCO, the hospice provider should bill the hospice services to the CCO and the room and board to DMAP. So no, if a client is Medicaid eligible and they're enrolled in a CCO, then and they also reside in a nursing facility and receive hospice care, then that hospice service and that nursing facility service are billed directly to DMAP. So that's when your hospice service kind of becomes carved out of managed or coordinated care as well. So the only clients that you would be billing to an Oregon Health Plan coordinated care organization or managed care organization are hospice clients that are outside of nursing facilities. And Judith, I wanted to ask if, excuse me, let's say the client does have long-term care insurance and they are in a nursing facility and they're receiving hospice care. So if the nursing facility is collecting the long-term care insurance payment, is the hospice then reverting back to their payment process and billing the plan?
Yeah.
Okay, I just wanted to confirm that. So the only time that you would have a client that is receiving hospice care and residing in a nursing facility and they're Medicaid eligible, so hospice providers, the only time that you would bill that client's services to the coordinated care organization is if the client has long-term care insurance and that amount is being collected by the nursing facility. Next question. So we bill OHP, submit online, when the patient has a CCO or MCO, and through DMAP, Medicaid directly, when they have open card, correct? So again, you would bill, so for hospice providers, you would only bill the plan if your client is not residing in a nursing facility, or if your client is residing in a nursing facility, but they also have long-term care insurance that the nursing facility is collecting. Next question. Although the state will not participate in the business contracts between hospice and nursing facilities, other regulatory agencies and legal requirements exist to govern anti-competitive inducement and fraud. So, while the state may defer on business contracts, other entities govern legal and regulatory requirements. Great, thank you. Next question. If a dual-eligible hospice patient is sent from home to a nursing facility for therapies unrelated to the hospice diagnosis, will this process work the same?
So at the point that they're in a nursing facility receiving long-term care services and they have elected hospice, then this is the process that must be followed per the Social Security Act that we're listed in the resource. So yes, we would go under this process. Again, some of the things to think about in those situations, that's the reason for the coordination. If this person was at home, is this the same hospice organization that your nursing facility is contracted with? Again, they may have a right to the service for hospice if your nursing facility provides that service, but not necessarily to the contractor, only the contractors that you all are contracted with as part of your business mission. That's, again, you know, as you do admissions and that process, that's something to look at. But yes, if they are receiving long-term care nursing facility services through Medicaid in the facility, then in the nursing facility, then yes, we would follow the hospice process that's outlined in the patient.
Okay, so we do have a comment coming in. We may want to consider doing some examples on how billing is done for hospice. There does seem to be some confusion or opportunity to clarify different scenarios. I would be happy to help. So that is one of our, this is the Oregon Hospice Association speaking up there. Awesome. All right, thank you for that. All right, so next question. Do hospice providers begin billing the CCOs for room and board in January 2014?
So no, again, nursing facilities, so the payments for nursing facilities or any of our APD long-term care settings are carved out of the CCOs. So that means in 2014, and at this point there is no statutory time frame for those being included in the CCOs. So again, the room and board portion is really the long-term care portion of the payment for the individual receiving services. For all intents and purposes, it's the APD payment. That is still carved out at this point and is not part of the CCO. There may be a point where it could be looked at, but again, we'd either have to look at statute or have legislative changes for that to be part of the CCO, or DMAP working on some redefinitions around the service, specifically for hospice time. So there is not a time frame for billing CCO for the room and board portion related to payments.
All right, next question. Do you think nursing facilities will refer less often because of the turnaround time for payment of the room and board?
So we hope not. First off, we hope that continual service and individuals being able to access hospice services isn't diminished because of this process. Again, first off, just clarifying, this is to implement and become compliant with federal statute. So this state decision was based on federal statute and making sure those rules and regulations we're compliant with. But the goal is, if a nursing facility is providing the services, they should still ensure that clients have the capability to access the services and that they're aware the services are available in the facility. Hospice is a service available through their medical plan, so it's available through Medicare and their Oregon Health Plan, so individuals should have the right to receive it if your facility offers it. We understand there could be some opportunity for better coordination on the billing portion of this, and that's, again, part of the reason for these trainings and really the focus on coordination between the different provider entities and your contracts to ensure that those areas are addressed.
The next question is the reimbursement rate from the state to the hospice provider less than the nursing facility receives currently for, say, Revenue Code 658? No. That's one of the changes. Oregon Medicaid is going to pay 100%. Okay, next question. Do nursing facilities know that there is patient choice and nursing facilities should disclose all hospices in the service area? Well, if not, I guess they know now. Because that just came up.
So again, yeah, so an individual and with all services, and I think, nursing facilities, as you look at these other services, could be an oxygen supplier, all the rest, are aware that clients have the right to make choice and be able to look at services and state how and where they receive their services from. But again, the key distinction there is that the nursing facility doesn't have to contract with any other hospice organization. That's a business decision about if they're going to provide the service, and that's part of their services, who they contract with. So we covered this on call yesterday, but again, a client may choose a hospice organization the nurse facility doesn't actually contract with at this time. And then there are a set of, decisions that have to be made by that client in coordination with the hospice, with the family, with local APD, AAA offices, and the nursing facility around that individual, whether they want to, one, continue to elect hospice. That's a decision for them, working with their doctors and their care plan teams around if they want to continue to elect hospice. They want to stay with that provider. That's a decision. They could switch to the hospice, to a hospice, because nursing facilities can contract with multiple hospices, but they could switch to a hospice that is contracted and stay in the facility. If they want to stay with that hospice, then essentially they're making a decision that they may not be staying in that facility since that facility is not contracted, and then they need to be looking for placement outside the facility. Again, the nursing facility has the responsibility to coordinate the discharge for the individual and ensure a safe discharge plan. So again, that's part of the reason for that coordination, and really focus on coordination throughout this process.
And I'll just add a little bit to what Nathan said, back to that question where the second part of it is, should the NIFs disclose all hospices in the service area? If there's 10 hospices within the nursing facility area, the nursing facility would not be responsible to disclose each and every hospice to that individual resident to say, there's this many hospices within that area. Hopefully, the nursing facility is going to want the best care for that client, but it wouldn't be the nursing facility's responsibility to disclose each and every hospice in that area for that client. It's who they contract with. If the family has a choice as far as a preference to a hospice and the nursing facility does not contract with that hospice, they can either choose to contract with the hospice, like Nathan was saying, or if the resident and their family prefer to go to that hospice and the nursing facility does not contract with that particular hospice, then the nursing facility and the family could work to place the resident at another facility that maybe does contract with that hospice.
Okay, and just another comment coming in from Oregon Hospice Association. Both groups share the goal to improve care to patients and their families. So very good. Next question. Please go over again. If a patient is covered by a CCO, the room and board is billed to DMAP, but hospice is billed to the CCO. So if your client is on hospice in a nursing facility and they're enrolled in a CCO, you would bill both the hospice and the nursing facility services to DMAP directly. The only time if your client is on hospice and residing in a nursing facility, the only time that you would bill hospice to the plan is if that client has long-term care insurance and the nursing facility is collecting that from the client or the client's family. Otherwise, you would bill both services to DMAP directly. Next question. Does the nursing facility have to pay for transportation of the patient if the nursing facility chooses not to offer hospice?
No, the nursing facility would not be required to pay for transportation. They can disclose up front if they provide hospice services in their facility at the time of admission. And if they do, then the family may choose to have hospice provided when that time comes. But if the nursing facility does not provide hospice or does not provide hospice with the hospice provider that the family is wanting to have their family member provided under, the nursing facility would not be responsible to pay for transportation to a facility that does provide hospice.
Another comment, the OHA continuously educates hospices that nursing facilities can contract with 0 or many hospices. Oh, by OHA, she's saying the Oregon Hospice Association, not the Oregon Health Authority. Good call.